got a whole chapter to do yet.
Exciting stuff. All right, it's 11 o'clock, so we get started. The sign-in sheet's rolling around, so make sure you grab that. Obviously, we lost yet another day, right? So, guess your exam's next week. Mainly, we got 41 slides to get through today. I also have an online class to deal with, and someone would like to take the exam with you all, and they're taking their exam this week, because they're online, so they didn't have to get affected by the days off. So I had to slide their exam back a little bit and tell them to come on Tuesday if they wanted to take it in person. So that means y'all get to wait till Tuesday too. So even if I get through this information a little too fast on today and Thursday, you still don't have to take your exam till exam 2. Now the trick to that is the same thing I told my 141 class at 9:30 this morning, which they were all up in arms about. Same thing I told you after exam 1, right? We still got covered material. So, there might be a couple of chapters that we might have to go a little faster. Might have to do, like if I end one a little early, I might have to start the next one without, instead of letting all go. So just keep that in mind that, we do still have to keep up. I'm going to try to get us back on track by, the second or third week of October, hopefully. So anyway, chapter 16, unlike 14 and 15, are pretty straightforward, I think. It's a lot of vocabulary, but there's no mechanisms you necessarily have to worry about. There's no, like following the cell, like we have to do with the macrophage all the way through both the innate and adaptive system. So this one, hopefully, you'll find a little bit more easier to digest on the first round or two. So a glimpse of history. This is going to be talking about host-microbe interaction. So we're flipping the switch a little. We're flipping the script a little bit. And instead of talking about the immune system like we did for 14 and 15, we're talking about what the microbe actually does. Like what is its role in the disease pathways. And so as you can see here, it's going through a list of how did we even understand that microbes were what was causing disease. We have, Moses, Egyptians, Hebrews believe that leprosy was transmitted by contact. We know now it's actually Mycobacterium leprae, and it's actually caused by, it's a more of a respiratory disease than anything. Euclid thought that plagues were contagious, many accepted by Middle Ages. Again, that's true. Plagues are, contagious, but this was the first time that somebody actually said it out loud, believing that might have been the case. And then Pretorius came across saying communicable diseases caused by living agents passing one person to another, but he had no way of testing it. It wasn't until Robert Koch, as we can see down here at the last one, that actually was able to put the nail in the coffin saying that microbes were actually what was causing diseases. Leeuwenhoek, as we knew from chapter 1, was one of the first people to see diseases in a microscope, or at least see microbes in a microscope. But it wasn't until Robert Koch in 1876 came up with Koch's postulates, which is what we'll see in this chapter as the actual way that we test, still to this day, test microbes in order to understand if they are truly the causative agent of disease. So bacteria are ubiquitous, right? Ubiquitous, if you don't know this term, means everywhere, omnipresent. So bacteria everywhere and anywhere, not necessarily nowhere you can go without being with them because they're always with you. We contact lots of different microbes every day. People you talk to, places you go, things you touch. Every day, covered in bacteria, covered in microbes. And so our body has that way to fight it off. We're breathing them in, we're eating them, we're drinking them, we're picking them up on our skin through touch. Vast majority of them, luckily, are harmless, right? That's why this class is not a transferable microbiology class. It's only for allied health majors, because the majority of microbiology is actually harmless to humans. 98% of it is harmless. So if you take general micro at 210, that's the transferable micro. This is mainly, of course, just for allied health and nursing majors. Some main colonized body surfaces, so we'll be talking about Staph epi, Staph aureus, both of them colonize the skin. So when we get to the skin diseases, we'll be talking about them. But at the same time, they're really not that they're really not that harmful unless they end up in some place they're not supposed to be. A lot of them are going to be sloughed off by the dead epithelial cells. Going back to chapter 14, remember your skin is a huge part of your innate system. And so what is the skin's always doing? It's always cycling. So every couple of weeks, you have a new layer of skin with the cells bacteria that may landed on your skin. They're getting knocked off with that old layer of skin that's being removed all the time. Any that we swallow get destroyed either by the lysozymes that we talked about in chapter 14 or by the stomach acids. Again, all part of the innate system. So anything that we digest, hopefully the majority of them are going to be destroyed. One of the things we'll talk about in this chapter is some of the stuff that we said earlier about infectious dose. So how much of it did you actually take in? How much of it did you actually consume? There's going to be a certain thing where certain doses are going to be dangerous. Other doses, maybe a dangerous microbe, but if you don't take in enough of it, it's not actually going to cause disease. The few that are able to cause disease, again, we're seeing some of the nomenclature. So this is nomenclature to make sure that you're making flashcards, making sure you're understanding. This chapter is mainly nothing but nomenclature and vocabulary. So here's one, pathogens. Pathogens, part of the title of the actual course, human pathogens, are the ones that actually cause disease. So as we've seen, most of them are harmless. Many are beneficial. So we'll see where they're actually beneficial as we go forward. But next vocabulary term, normal microbiota, or also known as your normal flora, depending on what books you're reading, what information you're going after. Those are interchangeable terms. Flora, microbiota, same difference. These are the ones that we've been talking about for a couple of weeks now, the ones that actually live within us, on us, actually providing services for the most part, or are just mainly taking up room, right? If we put the no vacancy sign up, pathogens don't have an opportunity to actually come in and cause disease. So this relationship is a delicate balance, right? A lot of things can knock them out. And so this can cause disease should the opportunity arise. We're going to be seeing another term moving forward called opportunistic pathogens. Opportunistic pathogens are ones that normally do not cause disease, but if given the opportunity, they can potentially cause harm. And so this whole relationship between all these different microbiota that live on us and us is very, very easy, very fragile, and very easy to break sometimes. Weaknesses or defects in the innate system or adaptive can lead individuals vulnerable to invasion. And so, either one of those, it could either be due to traveling. Say you travel overseas, you're now going to be around different microbiota than what you're normally around. Even moving from state to state sometimes can cause an imbalance because your body's not used to it. We call it traveler's diarrhea. You're sick for a day or so, you may have loose stool, for a day or so after you travel, or right when you arrive. Why? Well, because the microbiota is switching over in your body. You're having different ones that you're interacting with, things that your body's not used to seeing, and it takes a minute for it to find its balance again. Other ways could be autoimmune disease, right? Things that actually cause your innate system not to work properly or your adaptive system not work properly. Many different things can go around. We'll also see that antibiotics play a huge role in throwing off the system too. So individuals are said to be immunocompromised if they have any of those issues. So if they have any imbalance in their innate or adaptive system, we call them immunocompromised. And this could be either permanent or it could be acute, where it's just essentially something they're going through in that moment in time. So factors can include malnutrition. If you're not feeding yourself properly, your immune system's not getting the right nutrients, things aren't functioning correctly. This isn't just missing a meal. This is people that are chronically food insecurity problems where they're essentially not knowing where their next meal is coming from at any given moment. Folks like that are going to be in a situation where they're immunocompromised. Cancer screws up your system in more ways than one. Definitely causes the immune system to have to be fighting multiple battles. And so when it's doing that, it's not able to put full concentration into just that pathogen because it's actually over here fighting another front with the cancer cells. So immune system tends to have difficulty sometimes doing more than one thing at once. AIDS, of course, we've seen before, autoimmune disease. Essentially, your T cells are gone. Your CD4 T cells. So anything that requires T cell dependent activation of the B cells that we've seen in chapter 15, if your T cells aren't there, they can't activate. Therefore, the immune system's always going to be in an off position. So that'd be definitely an immunocompromising situation. Several other diseases out there that lead to immunocompromising situations. Surgery, you're opening up wounds. Immune systems have to go in and have to close these up. Yes, they did go in and suture, but ultimately our immune system's, doing the finishing touches, doing all that extra work under there. Having any sort of wounds is going to basically open up to the sterile areas, and that's going to allow these microbes to have a chance, those opportunistic chances to get into places they shouldn't be. Alcohol and drug abuse, we already covered genetic defects. Alcohol and drug abuse, again, this isn't going out and having a couple glasses of wine or a couple beers or something like this. Is people that are alcoholics, damaging their liver, damaging their kidneys, causing the immune system not to function properly. We'll cover drugs when we get to the wound infections, especially when we're dealing with people that do intravenous drugs, causing, especially with needle sharing, a lot of problems there with pathogens. And any sort of organ transplant surgeries, all this can be complicated because people that are organ transplants have to be on immunosuppressive drugs. That's going to then make them immunocompromised. So all of these different variations can lead to immunocompromising situations. It's not just one or the other.
Would allergies be considered an acute immunocompromised issue?
I wouldn't say it's immunocompromising, but it's definitely an acute situation.
Okay.
It just depends on what allergy we're talking about. One that's actually going to cause them to go have an anaphylactic shock. That's serious. If it's just something where you have a little sneezing fit because of pollen, I would say that's just part of the normal immune system functioning properly. All right. Chapter 14, right? This material is all chapter 14 material. We have skin and mucous membrane or barriers. So this is the biggest part of the innate system. Also hosts a complex ecosystem of microorganisms. This is going back to the idea of what we've seen in chapter 1. We have the normal microflora. We actually have what's called the Human Microbiome Project, which was started in 2012, 2013, something like that, where they started trying to catalog all the different microbes that live in humans or on humans. And it got up to somewhere to the tune of over 10,000 different species that live within us. Some of them are just there being boring. Some of them are just taking up space. Others are important for producing amino acids and vitamins that we need that we don't get from any other source in our diet. And so they're absolutely required. And so they're going to fit underneath at least the helpful ones are going to fit underneath two different categories. So we got three major terms here on this slide. We got mutualism, commensalism, and parasitism. So mutualism is when both partners benefit. You're in the perfect roommate situation. Both of you are contributing something, right? It's basically both are doing a service to each other. One's providing something to the other's providing back. Both happy. And so for us, that'd be the microbes that we allow to live, as an example, it's not the only one, as the ones that live in our large intestines. They're producing two major vitamins, D and K. We can't really have those. We can't find those really anywhere else. And so these bacteria, as part of the byproducts that they're making, they're actually just waste products to them. But to us, they're beneficial. Vitamins B, which is the energy vitamins that you find in Red Bulls and Monsters and all this, is basically bacteria waste. But ultimately, is B vitamins, K vitamins also are important. So this is mutualism because they're providing something to us. We're providing them with a place to live in terms of large intestine. Commensalism is one partner benefits and the other one's unharmed. So I think this is like the idea of a roommate that is never home, but they're still paying the rent and paying half the utilities, right? They're never there. You don't recognize them, but at least you're getting the benefit. They're really not getting much out of it. So the other's unharmed. So a lot of them live on our skin. They're just taking up vacancy. They're not necessarily doing anything that's helping us. They're not providing a resource to us. They're just taking up space. And by taking up space, that prevents pathogens from being able to sit down. So commensalism, one partner benefits, the other's unharmed. Parasitism is going to be when one benefits at the other's expense. This is having the nightmare roommate situation that's basically stealing all the food out of the refrigerators, went to the grocery and bought, causing parties at 3 a.m, basically making your life a nightmare. These are going to be the pathogens, right? These are the ones that are going to actually cause problems by making us sick, and we're not getting anything out of it, right? We're actually miserable. And so one of the things I want to point out, what is actually up there on the PowerPoint, is that when you actually talk to somebody that's a eukaryotic pathogen expert, they actually call anything that's larger that you can actually see with your own eyes, like worms, ticks, mites, fleas, all these are parasites. These are actual disease-causing, organisms. We call them parasites, but here the word parasitism isn't referring to that per se. We're just referring to one organism benefiting while the other one does not, actually gets harmed. And so just keep that in mind that there's sometimes, again, English is weird, right? There's certain words that mean different things depending on what context you use them in. Here, parasitism is just a definition, where a parasite is something different. All right, so normal microbiota. We have the resident and transient. Again, nothing but terminology in this chapter. So resident microbiota are the ones that inhabit sites for an extended period of time. Can your resident microbiota change? Absolutely. When you leave the locale that you're in. So let's say you decide to permanently move to Paris, and you're going to stay there for multiple years. Your resident microbiota are going to change. But if you just go on a trip, you're on over to Paris for a week or two, your normal microbiota are not going to change. They're still going to be there. They're there for an extended period of time. What may change are going to be what's called your transient microbiota. Those are the ones that are there for a short period of time, inhabiting temporarily, and that's usually going to be picked up during traveling or some other major event where you're not doing your normal routine. Something that's different from your routine. Maybe even change jobs, and now you're working with a different group of people. They're going to have different microbiota that can actually change the way that your body operates too. So these are both important to human health. Both of them can have a role to play in the human health. However, there's very little known about all the interactions. Why? You tell me why. There's 10,000 plus different microbes that live on the body. Trying to understand how all the roles that are being played and all the different. It'd be like the craziest sitcom you've ever seen in your life. It'd be like you're trying to figure out all the different people and all the different roles that they play in everyone's life. Think about it at a microbial level. We're really only touching the surface here in the last few years of understanding what role these actually play. So basically, since the Human Microbiome Project was initiated this decade, are we really even starting to understand the roles? So the picture, since we're slowing down a little bit, it's just giving us a lot of the different organisms that we're going to be covering for the rest of the semester. It's giving you their genus name, not their species name. So remember, bacteria have both a genus and a species. And so in the nose, we'll talk about Staphylococcus and Corneobacterium in the respiratory disease chapter in chapter 21. Throat, Streptococcus, Moraxella, Corneobacterium, Haemophilus, Neisseria, Mycoplasma. All important, all ones that we'll see later. So, definitely take some time. I'm not going to ask you any questions on the exam on Tuesday on these guys, but take some time looking at them because they're going to pop up again. You're going to see them individually as we move forward. So to protect the role of the normal microbiota, significant contribution against pathogens, right? So these are going to be doing multiple things, but mainly it's all part of the innate system. What are they doing? One, they're covering up all the binding sites. So the pathogens can't find a place to attach. Remember, the very first thing that has to happen in order for a pathogen to cause disease is they have to attach, usually to epithelial cells somewhere in our trachea or esophagus or even in the intestines. All epithelial cells going to attach, and then once they attach, then they have to invade. So if they can't find the sites for attachment, then they're not going to be able to cause disease. Consumption of available nutrients. Again, why would I want to go in a situation, if I was a microbe, why would I want to go in a situation where there was nothing to eat? It's already, sort of like showing up and, to a party and say, grand opening of a new restaurant or something. Like, oh, we got some free food. By the time you get there, if you're a few minutes late, it's all gone, right? There's really no point in staying. I've done that many times. You go like, oh, well, we got 2 or 3 egg rolls left. All right, we'll go somewhere else and eat. Sort of the same thing a pathogen's doing. It shows up, all these other microbes are already there eating up all the nutrients, and it's like, well, what's the point in staying here? I'm going to move off to somewhere else. And so that's a key part, consumption of available nutrients, protecting them from being able to actually sit down and then start multiplying. Because why would I multiply if I was a pathogen if there's not enough food even for myself? Production of compounds toxic to other bacteria. We'll be covering this in the next chapter, in chapter 20. We'll be going through a lot of the antimicrobial medicines. It's really the only time we talk about pharmaceuticals per se as a chapter. When we get up into the other chapters, we'll be covering what pharmaceuticals we use for different microbes. But chapter 20, we actually get into how they all work, the mechanisms of how these different antimicrobials work. Well, the key is most of them are actually produced by nature already. We just take advantage of them. So penicillin, amoxicillin, ampicillin, all these different antibiotics we have are actually compounds being produced by other microbes. We just discovered them, and then we basically grow them up in large numbers, and then we sell them as a pill. And most people take them, don't realize it's what it is. But third bullet there, production of compounds toxic to other bacteria, that could be in the form of antibiotics. It could be in the form of some of the stuff we talked about before, like the reactive oxidative species, producing hydrogen peroxide or producing superoxide, some of these other chemicals that maybe they're able to handle, but other microbes wouldn't be able to. When killed or suppressed, pathogens may colonize. So if I end up taking an antibiotic, say when I used to work overseas, we have to take ciprofloxacin with us. Cipro is a very strong antibiotic. You take it when you have no clue what the heck's wrong with you. You start feeling sick, you're in the middle of nowhere in Mali, and you don't have any access to a doctor anywhere, you start popping Cipro. Well, the problem with Cipro is it's going to take out everything. It's going to take out your normal microbiota, and it's also going to take out any potential pathogens out there. So it's a 2-level problem. We may be getting rid of them, but it's sort of like me going and wiping the whiteboard off. It's a brand new start. Who's going to be the first ones to get there? Hopefully, the normal microflora come back and colonize relatively quickly. But sometimes the pathogens show up first. And so we'll see this as what we call a secondary disease. And so sometimes after your initial infection, we put you on antibiotics, and then you're right back in the doctor's office with something else a week later because you basically knocked out all your normal microflora. All of a sudden, there's a bunch of nutrients available. All of a sudden, there's a bunch of space available because now the pathogen's able to go in and establish disease. And so this is a big role to play for those of you that are wanting to become nurses and actually work with patients, is that we have to be able to tell patients no when they come in and say, well, I need an antibiotic, I don't feel well. I don't care. It's not a bacteria. It's not going to fight a virus. Giving you an antibiotic is actually causing more problems than it would to just allow the virus to run its course. Antibiotics do nothing against viruses. And so now, what used to be a really hard conversation to have with y'all, now it's basically becoming public service announcements I see all the time. There's actually a billboard outside the Superdome last semester that was like, antibiotics do not cure the common cold. I was sitting there laughing, going, wow, finally somebody's actually posting this information. But it's important because, again, you can actually be causing detriment to the patient versus helping them.
They need to do it for the flu, too.
Yeah. Flu, any virus. Yeah. Okay.
How long, after taking antibiotics, does it?
That's a good question. So she asked, how long does it take for your normal microbiota to come back after taking an antibiotic. Depends on how strong the antibiotic is, and also depends on nutrition. Nutrition. I was going to say all the other things we talked about, how healthy you are already. And then remember, most bacteria that are in their proper environment will replicate every 20 minutes. So usually only about a day or two before, once you clear the antibiotic completely out of your system. Because even though you've taken your last pill on day 7, it still takes like a day or two for it to clear out. And then another day or two after. So I'd say less than a week, but still, during that time, you're susceptible.
So,
Go ahead.
oh,
Did you have a question back there?
Yeah.
All right, what you got?
Why is it so important for someone to, like, if they say you need to take this antibiotic for 10 days, why is it like so important that you actually take it like the 10 days?
Well, because we'll get into that in the next chapter. That's a good question because what actually is, so I'll use the same analogy when we do chapter 20 in a week or so. So imagine that when you take the antibiotic, you're putting pressure on the bacteria. As long as I keep that pressure down on them, eventually they're going to succumb. But if I play with that pressure, what nature does is finds a way, right? And so it'll actually mutate. And so a lot of our antibiotic-resistant bacteria that we're now dealing with today are ones that have learned how to get around the antibiotic. So if you stay on it for the full 10 days, even though you might start feeling better on day 4, day 5, and trust me, I am guilty of this too, forgetting to take the last couple days worth. But ultimately what happens is you're opening yourself up to potential that those bacteria that may still be left have mutated. And now they're going to start growing. And now
That's only harmful to you. It's not harmful to other people who would get that same sickness.
it could.
Like because I didn't finish it,
Yeah.
it's going to hurt you worse.
If it mutates in you and then you transfer, if it's a communicable disease and it transfers to somebody else, and now they're going to have the antibiotic resistance. So what we'll see in chapter 20, I think we touched on a little bit in this chapter too, is that one of the most dangerous places to catch antibiotic resistant microbes is where? Hospitals, right? Because they're already sick. They already got it. And so you can also basically mimic that at home by potentially not staying on your antibiotics for that long.
I was going to say, so what's like the Cipro and it clears out all the bacteria. Could they give you like a probiotic while you're taking it, so that could be the first thing?
You can. So that's a new trendy thing, right? Is probiotics, but there's actually not a whole lot of evidence out there showing that probiotics actually do what we say they do. My example is one of the biggest problems are women that get yeast infections are because they're usually on an antibiotic or maybe they have some other secondary. You take a probiotic by your mouth, right? How's it getting there? There's really no straight travel path. So essentially the question is, well, are they really doing their job? Probiotics, or is it just another marketing technique that we're selling? There's evidence out there in both, but it's not like established. It's just like any other thing that we sometimes jump onto and go, oh, this is a good idea, and then we find out later, oh, that killed a lot of people when we did it that way. Probiotics are that new trendy thing. You have any other thought on that?
I mean, we tell people, especially the kids that have a lot of diarrhea and stuff, tell them the Cultrell.
Mm-hmm.
Or there's also the lactobacillus that you get from the pharmacist.
Mhm.
Mostly just tell them to eat just regular yogurt.
Yeah.
Because of the positive bacteria.
But
They don't
that-
say anything about probiotics.
But that's a digestive disease, right? Because so that makes sense. You take a probiotic, well, not saying probiotic, but lactobacillus, which is one of the most important ones. It goes in, it's actually going straight to the
So
intestine.
there's a supplement of just like
It's a little package. You ask the pharmacist, you don't need a prescription.
It has to stay cold usually, I think, unless it's lyophilized, but yeah. Any other questions? See, I'm glad y'all are okay.
I have a quick question. So when the microflora is killed, it suppresses the pathogens, or it suppresses the pathogens, and then they colonize, like they hide. Or
No,
I mean,
everything's wiped out. So imagine I got a clean slate, right? So I
but
take,
how does the secondary infection start? That's just my question.
how does the secondary
Yeah.
start? Secondary starts like clean slate, right? I take Cipro. Cipro is what we call a broad spectrum antibiotic.
Right.
Wipes out everything. Clean slate. Who's the first one to get back there and start colonizing? That could be a secondary. It could be a pathogen. It could be the normal microbiota. So
it was killed when they took the sip.
everything's
so
wiped
nothing
out.
hides. It dies, but it just comes back.
It's whoever's the first back.
But why does why is it more eager to come back?
It's not. It's just who gets there first.
Okay.
Yeah. So if pathogen happens to get there first,
Or if the
Or-
normal flora gets there first.
But
Okay.
the chances of normal flora getting back there first are much higher because those are the flora that you're actually living with on a regular basis. So, the same foods that you're used to eating, the same places you're used to staying, all that's going to healthfully invite back the normal microbiota much faster. But if a pathogen gets in there, then it has a chance to actually start establishing disease then.
So like with the lactobacillus, if you were to take too much of it, could it cause like some kind of effect?
Lactobacillus is pretty boring. It doesn't really cause any secondary diseases. Actually, all it does is actually causes, what it causes an acid drop, pH drop. And so that pH drop actually causes a lot of pathogens not to be able to survive because the pH is too acidic. And so it's actually not a bad, but I've never heard of anybody having a lactobacillus infection per se.
Just a quick question. You were talking earlier about drugs and alcohol.
Mm-hmm.
I have almost 3 years clean of drugs and alcohol. So does your immune system eventually get better after so many years of not doing?
Your liver usually regenerates within about a year or better as long as it stays clean. And then after that, that's the biggest thing we're concerned with. But any damages, you're probably always healing. When you get up in age, it has much harder, you have more difficulty.
I say that if you did some meth or whatever for 10 years, it took 20 years you did it to so many years.
No, there's no clean cut equation. That X equals Y amount of time that you have to wait till your immune system is back. The healthier you make your immune system, the faster you get back to living a healthy life and keeping all those negativities out of it. It's going to heal. Now, how long does it take? Again, that's the magic of where we're at right now in society is we don't truly know. We understand that everybody's genetics is a little bit different. Everybody's metabolism is a little bit different. All those things are going into play in terms of how fast a person can heal. Age is a huge factor too, so age is on your side. Whereas somebody might finally realize after 20 years and they're up in their late 60s or something and saying, I'm not very clean because I'm having all these health issues. Everybody's going to have a harder time recovering and actually getting healthy again versus somebody that figures it out a little earlier in life.
Why, when you take antibiotics, do you often get
Loaded? I don't know. That's actually something I don't have an actual quick answer for. I've never experienced that. I don't know if that's again, that might come back to general, everybody's individual genetics.
I have a question about this antibiotic, what is it?
Ciprofloxacin?
Yeah, so, in the hospital base, would they give it to you orally, or would they give it to you through an IV?
Oral.
Really?
If you're in hospital, we do a lot of IV.
Oh, well, yeah. So I had oral, and then I always refer to her because she works in Oxford. So, yeah. I don't know. Where you at?
I work in the ER.
ER. Yeah. Oxford. So she's saying they do IV at the hospital.
Yeah, so, and it's run over a 4-course, or 4 hours, whatever, because it works better, right?
Because of the cell's absorption in it, they determine the times of how long. Usually with Cipro, it's about an hour. Your longer one is going to be Avalox, which is usually post-surgical.
Okay.
But Cipro is about an hour.
That's the stuff that I've never worked in the hospital setting. I've always been in the research side, so I always refer to the ones that actually work in there when I have them in the classroom. Any other questions? All right. So what we see there, some inhibit lactobacillus. So again, this is the one that then allows Candida albicans, or the yeast that actually causes yeast infections in females. When the lactobacillus is gone, it's not producing that acidicness anymore. The Candida albicans is able to grow. They're an opportunistic pathogen. They're already there. Candida albicans is there all the time. But in this case, if they all of a sudden have a bunch of free space, they start growing really quickly, ends up turning into a yeast infection. Some women are more susceptible to others. We'll cover that when we do the genital urinary tract infection. Oral antibiotics can inhibit intestinal microbiota, allowing overgrowth of toxin-producing things such as Clostridium difficile, or C. diff. All right. So protect the role of the normal microbiota. We're just going through all the different roles that they play. Stimulation of the adaptive immune system. So one of the things that we know is what we're going to call the hygiene hypothesis. This is something that I think, again, just like people thinking that antibiotics cure everything, I think this is a generational issue, and hopefully it's going to autocorrect itself soon. But one of the things that really started happening when people started living more inside, TVs were invented, the internet came around, everybody just feels like, oh, they want to be inside. It actually has a detrimental role on your immune system because the more you're exposed to as a child and even as an adult, the better trained your adaptive immune system is. Remember how much effort it takes to get the adaptive immune system to come on, right? You're probably also trying to struggle on figure out chapter 15 and all the different players there. That's a lot of work. And so by doing that, you're training, getting more memory cells. You're also just getting the immune system more primed and ready. Sort of like, thinking about playing a sport. If you only go out and practice on the day that you go out and play, like my son's flag football team, they go out and practice a half hour before the game, you're not really gonna get that good. If you're like the Saints, you're practicing almost every single day, and out there, doing training in the off season, well, you're gonna get better and better. Your immune system's the same way. The more it's trained, the better it's gonna be. So stimulation of the adaptive immune system is key to actually allowing these normal microbiota, experiencing different things, eating dirt, as I say, let your kid eat dirt, because it's stimulating the immune system. So mice,
Huh?
Say
that again.
let the kid eat dirt. Let him eat dirt.
Ringworms like that.
Huh?
They get the little ringworms.
You're stimulating the adaptive immune system. Well, within reason. I'm not saying just let him go out there and eat dirt.
Well, it's like we were talking about hand sanitizer. I mean, we have hand sanitizer everywhere throughout the hospital.
Yeah.
And it's mostly got to do with the hygiene as well as people. We're not washing our hands as much. We have more people who come in from farming communities that are actually healthier than people working in the city because they're always using hand sanitizer.
Yeah. Right. So what she's saying there is the same thing that we're saying here is that yes, you can always do something in excess, but by completely avoiding it, you're actually missing out on some of the actual role that the
You're making
stimulation.
yourself more susceptible.
Yeah. So for instance, what I do know this because I have worked with mice that are what we call basically they've had their immune system knocked out genetically, and so they're born in the lab, but they're actually also genetically knocked out where they have no immune system. And so what they end up doing is those that we use those in the lab to basically be sentinels. So we might have 100 mice, but we have one that is basically susceptible to anything. If it gets sick, then we know that the other mice might be sick too. So we use them that way. Also like a bubble child that basically born without immune system has to live basically in a bubble or a very clean
Couldn't
home.
y'all use that to kind of like figure out what also builds the immune system or something?
Yeah, we do that all the time. Absolutely. But the key here is what I want you to do know is the hygiene hypothesis. The more that you're exposed, the better your immune system is going to be. The more you train it, the better it's going to be off. If you don't ever allow a child out of the home, or even as yourself, you don't do anything, you sit inside all day long, you're going to possibly have less of a chance to have a strong immune system throughout life. And so like she was pointing out, some, people that come from farming communities where they're basically outside rolling around dirt and, doing all kinds of, hard labor type stuff, they're much healthier than some people that actually live, doing day-to-day desk jobs because they're not actually exposed to a lot of the same things. And so this is a big key to understanding how allergies come about too. So children that tend to be raised in the home that doesn't really get a lot of outdoor exposure, they tend to have a lot more allergies than children that are, for like myself that was born on a farm and lived on a farm most of his life until I ran away, came here to teach you all. So you ultimately a lot of allergies. So where are all these allergies coming from? My generation behind me, we didn't have these same allergies that we're experiencing now. We didn't have peanut butter allergies. We didn't have these other weird allergies. It's because one thing changed in the last 30 some years. Internet, TV, people tending to stay inside more, not actually exposing to a lot of different things. And so now we're seeing a lot of these allergies pop up, and this is what we call the hygiene hypothesis. It's called a hypothesis, right? Because we haven't truly proven it yet. But there's a lot of evidence that keeps coming about for more and more, tests and different clinical procedures that are done, or clinical tests that are done that are essentially showing us that this might be the case. And a lot of this is coming up because we're not training the immune system properly. That's at least the way it was originally intended. All right, so the dynamic of the normal microbiota, healthy human fetuses are sterile just before birth. Right? As long as the placenta is doing its job and preventing any sort of cross-contamination or anything coming across the placenta, the human fetus is sterile. The second it is exposed to microbes is when it goes down the birth canal. So it gets exposed, its skin is essentially covered in all mom's microbiota as it goes to the birth canal. So what about a child that's born by cesarean? What do we do with them? Anybody been in the room when they do it? What do they do?
Clean them off.
Yeah, clean them off. We basically swab them with mom. And basically try to recreate that same idea of going through the birth canal because we want those normal microbiota to be there as soon as possible.
Placenta?
No, placenta's clean. No,
So like, what if the mom had some sort of like disease or something like that?
we'll cover that when we get to that chapter. But yeah, we do. We actually do. We do eye drops to prevent as well as other things. If we know the mom is sick right before like in the third trimester, we put them on medication, try to clear it, try to calm it, and then also we will do C-sections to prevent any
No,
sort
I
of.
mean like HIV or
Yeah.
something like that.
Yeah.
Like, there's
We'll do
ways
everything.
to prevent the baby from getting
Yeah.
it,
Because as long as it
even
doesn't
if they have them naturally.
it becomes a lot more difficult.
Okay.
As long as they're underneath proper supervision, and no real true medical provider, I don't think, will allow an HIV positive mom to have a natural. Right, they'll insist on the cesarean.
schedule.
So like herpes, just say like you have to have a C-section or you can have a baby.
That's why I
But
was
if you're
saying.
not, you can have it.
Yep. So so herpes, right? So you have flare-ups. That's what she was asking. So in the third trimester, we're going to be monitoring once a week, almost, if not be more, once a week is about what we do. And then what they're going to do then is just keep watching, and make sure, that you're as healthy as possible, and then allow you to make that choice when we get to
It's
that.
not like a bed rest type of thing. It's just
No.
like they just watch them and make sure.
Yeah,
It's
if
not
you're-
multiplying or something like that.
No, but like for herpes, you can have a flare-up,
Mhm.
right? So if you're having a flare-up at the time of, when you're supposed to be giving birth, we'll be doing the C-section. Minimize that, because that could actually. So what are we talking about here? I know there's other hands up. I just want to help make the connector why this is important. How long does it take for the immune system to come online?
6 months.
6 months. So a child that goes through the birth canal and contracts a disease such as herpes or HIV or gonorrhea or syphilis, what's going to happen to that poor child?
So it's like
gotta
a
be.
mouse without the immune system.
It's going to be hospitalized or it's going to be dead within a couple weeks maybe, because that microbe is going to destroy the poor child before the immune system even has a chance to come online. It can also end up having permanent disabilities. Blindness is a big deal, especially with gonorrhea. It
So
gets in
they
the eyes.
basically give them like something like synthetic that will fight it or something like that? Like
What?
the baby, like if the baby, like how she was saying, like if somebody's having a flare up and then they have a C-section, but is it possible like, that they could still catch some of those?
But keep in mind that it's always possible. But keep in mind that, as long as the child's inside the placenta, it's sterile. So when we go in, we cut open, we're going to pull the baby right out as fast as possible to minimize it catching any of those microbes or any of those microbes landing. But we're also going to do what she said, we're going to clean it as fast as possible too.
So they can't just pull it out still in the stuff?
No.
I've seen
And I wouldn't
babies
know all
born
this
still
if I wasn't in the
in
room when my son was
little
born.
bag. Yeah, I've seen a baby that was born in the little bag still, and they cut it open and it
Yeah.
just like comes out.
Yeah, not completely, but yeah, there are preventive. I guess the point is that we're trying to make in this slide. I know everybody's got a lot of questions, a lot of thoughts going through your heads. The idea is that the baby's sterile up until the point that it goes through the birth canal, and normal, healthy births are going to be the way that it actually gets some of its first normal microbiota. Now, we'll talk about, as we keep moving forward in all the other chapters, we'll talk about all the things that can go wrong and the things that we do to help try to prevent that. But ultimately, that's only those unique situations, right? Most people are going to have, not most, but Yeah, most are going to have healthy births, at least normal births.
Oh, when, normally when mothers have C-section, this is what I heard, because I want to go into birth, like the baby will come out and like the white stuff, is that what you're, I mean, not C-section, natural birth, but when the baby comes out, it's got all the white stuff on it, is that like the good microbiota?
That's-
No,
she's
that's
talking
something
about
that
the-
protects the skin while it's in the
Yeah.
amniotic fluid. It's like called Vernex or something.
Yeah,
It just
yeah.
protects your skin from, so that it doesn't get like if you carry a baby overterm, all of that will start to go away and the baby will come out like very like wrinkly and like dry skin. It's just.
Oh, okay.
No, you wouldn't be able to see the normal microbiota, but yeah, I mean, all of that's going to have. Well, it's basically the birth canal because remember, inside the placenta itself, it's sterile. So it's only when it actually breaches water breaks, it starts breaching through, and it's actually now touching the epithelial of the inside of the birth canal. It's now being exposed to all the normal microbiota. Now it's being transferred skin to skin, essentially.
Okay.
Any other questions? Wearing me out. It's good. I like all the questions. Sometimes especially when I got an expert in the room, I got to check myself. Or at least more experience than me. And plus, I got a lot of moms in here, I'm sure. And so that's certainly not up my alley of understanding all the pieces and parts. So composition of normal microbiota is dynamic. So what do I mean by dynamic? Constantly changing. When we use dynamic, the opposite is static. So when we use the word dynamic, we're saying that it's always changing. And that's the idea that it could be day to day. Your transient microbiota can change if you find yourself in a new locale that you're not used to being in. Or it could be your normal microbiota changing over to a more permanent if you actually move and you're changing jobs or you move to a new location, you're going to be exposed to different microbiota. So I can also be what's here. So let's say you're living a normal day-to-day life, and of course, hormonal changes, especially in females, is cyclic, right? Every month, and so hormones can play a big role in how the normal microbiota function. So some of them hormones can actually throw off the normal microbiota during that time. So we do see a lot of women that end up having yeast infections on a regular basis, or even bacterial infections on a regular basis, and that's just due to genetics as well as hormonal changes. Could also be consuming foods. Different foods are going to have different bacteria in them, and so some of these can actually change the way that your body reacts. One of the things that we're learning here in the last couple of years is that the intestinal microbiota, so the normal microbiota is supposed to be there, in the intestines is different between people that are lean and people that are obese. I'm not talking just having a few extra pounds due to an accident, not being very active. I'm talking about people that are medically obese, people that may have to be considering gastric bypass surgery type things. What we're now learning is that they actually have different microbiota in them, and so for people that are obese, they have more of the phylum Formiculates. I don't really say that one very often. So it's a different variation of bacteria than the ones that are found in the Bacteroides that are found in people that are more lean. And so there are these ideas of changing your microbiota to help with weight loss. And so does anybody know what they do for that? It's actually a new technique. Sounds really disgusting.
Is it a stool transplant?
Fecal transplants. So fecal transplants, they're a big deal now. They actually take the fecal matter and transplant it from person to person to change up the microbiota that's found in the lower intestines.
It's not what you think.
It's not as bad as, yeah, exactly. I like to make it sound more scary.
No,
But
that's
it's-
awful. Like that just, how is that not like a total health hazard?
Because it's actually being, right? It's actually being sterile. It's being sterilized more than you think.
So it doesn't kill
Is that
the.
encapsulated?
We're basically taking, yeah, it's encapsulated. Yeah, we're not just taking food and putting it in. It's encapsulated, but it's also
You're just
only,
taking stool from somebody, cleaning it, and then putting it in the
That's exactly what you're doing. And it's
And then you
usually a
swallow?
family.
it's usually a family member.
Yeah, you want me to
Usually a
swallow
young
the
family
capsule?
member.
In the capsule, yeah, you swallow.
Oh, no.
What did you say? It goes in the capsule?
They do.
They do.
What they do is they, if you don't mind, they give you a bucket. They give you a bucket after the family member's been tested for just about everything. They give them a bucket. And what they do is every time they poop, it goes into a bucket. they bring it into the hospital, it goes into pathology and into research. What they'll do is they'll take all the toxins out, sterilize it, put it in capsules, and the person will actually take it orally. But when you're dealing with something like C. diff, C. diff, basically you're crapping yourself to death. Or if you're a stroke patient, you've gotten septic, you have nothing in your body to protect you. And the only way you can really keep from crapping yourself to death is to build up everything in there that is breathing, absorbing, and making solid. So that's what they do. I've had 2 patients do that.
Can you use like an antispasmodic or something?
Antispasmodic.
No,
Not
not
like slow it down, build it up.
not if you're already septic, like she's pointing out as an example.
And it's not a first line choice. I mean, they try everything. They try everything.
So this isn't just like, oh, I wanna lose some weight. I'm
No,
not
no. She's telling you more from an acute standpoint. Somebody's a stroke victim, or somebody that's septic, or C. diff, which is going to be problematic, where it's a life or death situation.
So you would do that if you had C. diff, like you would have to take the.
Again, not as a first line,
If it's chronic.
but this is something that's relatively new, like within the last just half decade or so.
So what's in this cerebral disease? What's in it that helps them?
Your normal microbiota. Yeah, because you're always getting rid of normal microbiota during bowel movements, and so they can accumulate it up and then help it.
This is like the last resort.
Don't try it at home.
I won't.
Hey, C. diff would just be a bacteria in your poop?
Yeah.
Okay.
But
And it
it's
just
also
like smells
so
awful?
Clostridium. We'll cover it when we do digestive diseases. So Clostridium difficile is a bacteria. It's supposed to be there, but when it gets out of control, like when it becomes opportunistic, it can cause serious problems because it is a toxin-producing bacteria. And so they can cause things like sepsis and whatnot that she was referring to. So we can go back and try to put it back under control. Simplest way to think about it. See that blow your minds. Hopefully you walk out of here going, what in the heck did I just listen to for the last hour? Right?
Well, we've had some conversations of friends, but I didn't realize why they would do it. Like they were, because we had talked about the placenta too,
My
how
first
they
patient
happen like that.
was an actual donor, and then I have a lady who's, when I moved up to the North Shore, she had one, and they were constantly trying to see that. I mean, constant chronic, because she was on so many antibiotics. And she's actually doing good.
It's magic almost.
God.
Science is the closest we come to real magic, is what I always think. So, all right, so we'll keep moving because strangely, after 50 minutes, we've only made through 9 slides. All right, that's cool. Colin, I'm not pushing the exam back any further, I'll tell you that much. So, colonization. So the idea of colonization is when the microbes actually establish itself into the body surface. So basically when it first shows up, like we're going to go colonize Mars or the moon one day, right? So when the humans first show up, colonization, this standpoint, is when the first pathogen shows up. So the term infection is usually going to be used or restricted just to a pathogen. If it's normal microbiota that comes to colonize, we're not going to call that an infection, right? It's essentially supposed to be there. Now there is something called subclinical. So you can actually have a pathogen. A lot of people do. You can get a pathogen and have no clinical signs. And so we call that subclinical, where you have no noticeable impairment. But then the next two are very important for you to understand: symptoms and signs. Symptoms are going to be subjective. So these are going to be experienced by the patient, pain and nausea, right? So I have a lot of pain. Well, my pain might be nowhere near your pain threshold, right? So it's subjective. That doesn't really tell me a whole lot. If you're an intake nurse, or if you all move up to become doctors yourselves, somebody comes in and tells you they're in a lot of pain. All right, that'll tell me much. Just telling me, yeah, you obviously got something going on that made you come in, but it doesn't really tell me what it might be. It could be a muscle pull. It could be some sort of major infection. We don't know. Signs are going to be objective. Signs are something that gives me an answer, right? So in this case, a rash. Rash is going to tell me there's something going on. Pus formation, tell me something's going on. There's an infection going on that's actually causing this particular sign. So make sure you understand the difference between symptoms and signs. Symptoms are subjective. Signs are objective. And so this is going to bring us in next one. Initial infection is what we call the primary infection, right? So you can be having a primary infection, but then as we already talked about, sometimes those primary infections can lead to secondaries. Like the example that she was just giving about, the patient that was coming in because she was already on a ton of antibiotics and then C. diff came about. Well, Clostridium bacteria, which there are several, Clostridium tetani, Clostridium botulinum, Clostridium difficile, they require a completely different antibiotic to clear than the other bacteria that normally we'd give like penicillin or something to. Clostridium are a little bit more difficult to clear. So somebody that's on antibiotics, it's not going to affect the Clostridiums. Clostridium difficile is already there. It's going to start growing, because it's now got all this free space. It's going to start growing and then become a true full-blown C. diff infection, which then we would call a secondary infection sometimes, depending on the situation of that particular patient. So here, secondary infections can be ones that come about either from the treatment or because the immune system's already fighting a primary infection. The immune system has difficulty sometimes fighting more than one infection at a time. When I was up at the primate center, we were having primates that were infected with tuberculosis and then infect them with the primate version of HIV to see what happened when they actually had two chronic infections. Well, it may sound cruel, but you got to remember that 1/6 of the world population already has tuberculosis. So within that population, there are people that have HIV also. So the question is, does it cause them to speed up and die faster, or is there some sort of weird, crossroads that happens where essentially the immune system is then able to keep them both at bay? The question is, we don't really truly know. It probably comes down to people's genetics. It comes down to your age. It comes down to the same thing that I was telling Shane about, how long does it take after clearing yourself, like when you're healthy again. There's a lot of things that are going to come into play. But, essentially what you need to know is the two definitions, right? Primary versus secondary infection. Secondaries can come about from the primary, either the treatment or actually from the primary itself sometimes.
So the secondary infection, like with the secondary response, that doesn't really help with the secondary infection, like how in chapter 15 we've already had it, the memory cells.
Mm-hmm. Yeah, no, that's what's going to help you there. I mean, but if you wouldn't get a secondary infection from something you already had memory to. This would be something else that's coming
So
in.
it's something that's basically like, the primary is already in the process for the secondary.
So let's say you get, I don't want to say you, somebody has HIV. That's your primary infection. But we also know that people that have HIV then are more susceptible to pneumonia. That's a bacteria sometimes, or it could be viral pneumonia. But it's going to come in, that's your secondary now. You're already fighting something. Secondary is coming in because the immune system's busy and it has trouble fighting more than one front at a time. So just keep them completely, it's like, you get in a fight with somebody and then somebody comes behind you and clocks you in the head, right? That's your secondary infection. They have nothing to do with each other, but, right, it's overkill, right? Unfortunately, because the immune system's already busy, it has trouble fighting off a secondary case.
So secondary infection is like a primary.
No, they're treated completely different. You have your primary, you have primary infection that's causing XYZ problems. And then sometimes those XYZ problems that's being caused by the primary allows that secondary infection its chance to come in and cause problems too.
Like a respiratory and a ear infection.
Yep. So for instance, that, but I like her example better, the antibiotics. Somebody's on a lot of antibiotics. She cleared out all the normal microflora, but C. diff, Clostridium difficile, isn't touched by most normal antibiotics. It's already there. Now it's going to start growing out of control because there's all this free space. So now that Clostridium difficile has now become a secondary infection because it is growing beyond the means of where it's supposed to be.
So how do we protect someone that's in the hospital that just get off of surgery is on a strong antibiotic? There's nothing we can do.
You do your best.
And work.
Yeah, you lose people along the way all the time. Unfortunately. It's really, these are just things to be aware of, right? There's no way, at least with current technology, there's no way to save everybody. It's just not going to happen, especially when it comes to infectious diseases. So we have the primary and opportunistic, right? So primary pathogens are ones that cause disease no matter what, right? So something like, just because I'm stuck on them right now, Clostridium botulinum. There's no benefit to having Clostridium botulinum in you whatsoever, right? It's actually a primary pathogen. It causes sickness all the time. Influenza virus. Let's switch to the virus for a second. Influenza virus is a primary pathogen. It has no benefit inside you whatsoever. It's going to cause disease. Opportunistic are the ones that are going to take advantage of situations when the normal, innate, and adaptive defenses are down. So these are things that are going to be like Candida albicans. It could be a yeast infection. It's not going to cause disease normally, but when it's allowed to grow out of control because of those vacancy opportunities that may be brought on by antibiotics, it's going to cause disease. Something like Staph epi. It's actually epidermis. It's one of the normal bacteria found on our skin. You get a cut, now that bacteria is able to get into the sterile area, it can potentially cause serious disease. Same thing as Staph aureus. Much more dangerous one, but still can cause disease if it's given the opportunity to be places that it's not supposed to be or grow to levels that it's not supposed to grow to. And so there's a difference, right? Primary pathogens, always bad. Opportunistic can be bad given the opportunity, thus their name. You have virulence. Virulence is something that, is where I first started in infectious disease work, was understanding the virulence factors. Virulence is the degree of pathogenicity. How dangerous is that pathogen really? Is it something that can kill you within a couple of days? Is it something that's going to take a really long time? Is it something that's just going to give you a little bit of a sniffle? All these are going to determine what type of virulence that particular pathogen is. So you could be a primary pathogen but have low virulence. You could be a primary pathogen that has high virulence. Both are going to have different outcomes to the patient that actually contracts it. Virulence factors are going to be the weapons that that particular pathogen has to cause disease. All right, so for instance, what we have up there is toxin. So Corneobacterium diphtheriae causes diphtheria. The bacteria itself doesn't really do a whole lot. Bacteria itself is not the problem. The problem that causes the virulence, causes sickness, is its virulence factor, the toxin. The toxin it produces then causes the actual disease signs and symptoms that we experience. Same thing with Staph aureus. Staph aureus, its bacteria itself has a toxin it produces, but it also has it can potentially have a capsule. It can potentially have other virulence factors, and so it has multiple weapons on it. So this is things that, as a molecular geneticist, when I was working in labs, we were working on virulence factors. We were actually, we knew this bacteria caused disease, but what is it about that bacteria that causes disease? And that's going to be its virulence factors. And so just make sure you understand that those are the differences. You can have all kinds of different, you can run the spectrum of different virulence levels and as well as virulence factors. Just think about it as being, you can go into war or go into a fight with just a knife, or you can go in with multiple guns and grenades and knives and things like that. Those are all your virulence factors if you think about it as a bacteria. What is all the different weapons it's actually bringing with it, and how can we actually combat those as an immune system, but also with pharmaceuticals, understanding exactly what it is that bacteria or virus is doing. All right, so characteristics of an infectious disease, it can be communicable or contagious, essentially meaning the same thing. It's easily spread from person to person. But then we have to focus on the infectious dose. Just because somebody's sick doesn't mean that you're going to catch it, right? We have to know what it is that actually allows it to spread, but also how much of it you need. So the infectious dose is the number of microbes necessary to establish an infection. And as a research scientist, we always focus on what's called the IG50, infectious dose 50, which is the number of microbes it takes for 50% of the population to get sick. Now, we're not talking humans here, right? We're talking about whatever animal model we're using in the lab. So if it was mice, if it was primates, if it was ferrets, if we were doing influenza, ferrets are the only the only animal that actually sneezes like a human, so we use it as an influenza model. But essentially, okay, I might give them 10 salmonella when I was doing mice and we were doing salmonella work. Might give them 10. None of them get sick, right? So the ID 50 is 0. I mean, none of them got sick. I might give them 100, maybe only 2 out of the 10 got sick. That's not enough. Maybe give them 1,000, maybe only 3 out of the 10 get sick. Finally, when we get to the dose that causes 50% of them to get sick, that is our ID 50. That's the number that we're looking for to understand what is that number that's important. And so we look at that. So essentially, when we look at different types of bacteria that are related, Shigella and Salmonella are very closely related. They're basically kissing cousins. But the difference is Shigella can actually withstand the stomach acids. And so it takes very little of them, only between 10 to 100 to ingest the Shigella for you to come up with shigellosis, which is the disease that Shigella causes. But something like Salmonella, both of these are found in food, right? Food that's bad food, tainted food. In this case, Salmonella, it takes closer to 1 million. Why? Why the big difference, even if they're closely related? Shigella is able to handle the stomach acid, so it's able to pass easily through the intestines. Once it gets into the intestines, that's where it's going to establish disease, colonize, and start causing disease. Salmonella, you have to have 1 million because they're not acid resistant. So it takes a lot more for just a few of them that maybe survive to get into the intestine to establish disease. Once it gets past the stomach acid, then it's game on. But you may have to take well over 1 million of them to actually get to the chance of a few to make it to the intestine. Where Shigella, they're all acid resistant, and so it only takes a few because they're all going to make it past, at least in theory. So we have different ID 50s for both Shigella as well as Salmonella. So course of infection. So this is any disease that you have. You're going to have 3 major levels. There's 4 there. One is a carrier, so that's not necessarily for everybody. You're going to have an incubation period. This is the time between infection and onset. So somebody sneezes on you that's got flu. Well, you're going to be fine for the first 2 or 3 days, and you may be thinking to yourself, oh, thank goodness I didn't catch that. That's just your incubation period. That's the time when the infection is starting to develop itself and the onset of where you actually start experiencing those signs and symptoms. Now, so what we have there next is varies considerably. It could be just a few days for the common cold, like somebody sneezing on you, and then you're kind of lost in your mind of where you may have actually been exposed to it, right? Where it could be years for something like leprosy. It could be years and years since you were exposed to it before your body actually starts showing signs and symptoms. Illness stage is the one that we're most familiar with. So when you're ill, right? So, when you're not feeling well, that's your illness phase. That's when you have,
For the incubation period, like you said, that it takes a long time, like for leprosy to give you symptoms. Why wouldn't your affinity maturation cells be able to, the ones that do that and are fine-tuned or whatever, why would they be able to do that?
Good question. So good. I like how you're thinking. So leprosy is caused by Mycobacterium, and Mycobacterium has mycolic acid.
And
yeah, Mycobacterium. So remember, that's mycolic acid that we have to use acid fast stain for. It's more of a lipid, and remember, lipids don't make very good epitopes or antigens, and so bacteria such as tuberculosis as well as leprosy are both caused by a Mycobacterium. And basically, all the body can do is wall it off. Okay. But eventually, over time, that wall breaks down. Not everybody. Some people can live full life, but they're going to be subclinical, right? We're never going to know that they were sick.
So if it was made of a protein, then it would have
a better chance of fighting it off. Yeah.
Okay, so it's the antigen that's made of the protein.
Yeah. Well, antigens are anything and everything that causes an antibody to form, right?
Right.
Lipids make really pathetic antigens. So it's really hard for a bacteria that's covered in mycolic acid to get a strong immune system response.
Okay. All right.
So that causes, and also both of those species, the one that causes tuberculosis and leprosy, very slow growing. What I was saying earlier, where most bacteria replicate every 20 to 30 minutes, they replicate every 7 to 40 days, very slow. And because of that, they're also able to hide from the immune system because they're so slow,
So they're not lying dormant, they're just replicating.
incredibly slow. And they're also made out of something that the immune system is not able to fight very easily. So that's going to cause the incubation period to be different for them.
But can that also help though? Because if it's slowly growing, if you catch it ahead of time, couldn't you like?
If you catch it ahead of time, you can go on medicines, but until you actually know you're sick, you're not going to go to the doctor and say, I think I have tuberculosis, right?
Right.
Yeah. I'm just, it's
No,
obvious,
really,
right?
yeah, it's not.
Yes. So then you say subclinical, so you're not going to actually have any reason to go get tested for those things. All right, so let me get to this slide, maybe the next one. Illness, signs, and symptoms. We have what's called the prodromal phase that happens beforehand sometimes. Those are your vague symptoms. You wake up, you got you feel like a small fever, or maybe you feel like you got a little bit of a, lethargic, where you're just not feeling you got a lot of energy. Or you're like a lot of times you may wake up and go, dang it, I think I'm getting sick, right? Those are your prodromal phases. Those are the vague symptoms. They don't really tell you a whole lot, but you also know that there's something not right? So you start feeling that way. And then convalescence is your recuperation and recovery from disease. So which of those three phases are you typically going to be the most infectious? Incubation period. That's what maybe I like people say illness because that's usually what most people think. When you're actually sick, you think that when you're actually experiencing signs and symptoms, you think that that's when you're the most contagious. But for most viruses, especially viruses, it actually is during the incubation period. When you don't even know you're sick is when you're the most infectious to other people. And that's actually brilliant on the virus's part, right? Because what is somebody that's sick going to do? They're going to stay away, right? They're going to go and stay at home. They're going to stay away. That's going to prevent that virus from moving on. So it actually is brilliant on the virus's part to stay, basically hidden while it's the most contagious. All right, and then carriers. This is not part of the traditional stages of illness, but for some particular diseases, such as Salmonella typhi, you can potentially become a carrier. There are also some suggestions that people can be carriers of other diseases that we don't even realize that they are harboring. So you may harbor and spread an infectious agent for long periods of time, even though you are not sick at all. And so we'll talk about the famous story, Typhoid Mary, as we go forward and we get to Salmonella typhi. But essentially, she was a carrier. Nowadays, we know how to get rid of it. We can actually remove the gallbladder. People that have typhi, they're carriers, and that makes them healthy. How to get rid of it. But back when she was alive, unfortunately, the only thing we could do for her was put her into a insane asylum, basically keep her in isolation for the rest of her life. But we'll cover exactly how that happened as we move forward, in the other chapters. So last slide we'll do, and then we'll call it a day. Duration of symptoms, you're going to either have acute. These are going to be ones that happen very quickly and last a short period of time. So something like strep throat, you're miserable for a good 3, 4, 5 days, and then it goes away and you're able to carry on, healthy again. So acute symptoms. And then a chronic infection is going to be something like tuberculosis, right? Or something like herpes if we're talking about a virus, where you have it for life and it's always going to be there. So it could be for life, or it could be very long periods of time, such as tuberculosis. You may have it for years. We can clear it with antibiotics as long as it's not antibiotic resistant. We can still clear it, but you also have to be on that medicine for well over a year sometimes because it's a slow growing bacteria. And so the antibiotics you have to stay on for a long period of time. You have latent infections. This would be more the idea of like chicken pox. Especially for those that have had it. So never completely eliminated. The microbe still exists in the host tissue without causing symptoms. So essentially it goes in the latency period. Herpes, the same thing. Actually, chickenpox and herpes are the same family of viruses, where they go and they hide in your nervous system. And
Something that if you had herpes, then you couldn't get chickenpox.
no, they're two different viruses, but they're the same family.
So you can not have chickenpox and then still get herpes.
Oh yeah,
Yeah.
absolutely.
Had chickenpox.
Absolutely. Yeah, they're just two different viruses, but they're in the same family because they act the same. So in this case, they both go in latency. And so there are viruses that even though you may clear it, you start feeling better, you live a normal, healthy life, the virus is still inside you. And it goes and hides. And
So what are
so,
those like skin, would you consider chickenpox and herpes if they're in the same family? So it's like a skin kind of thing?
no, they get into the nervous system. It breaks out, you get a breakout on your skin, but the virus is actually hiding in the nervous system and travels through the nerves. And so that it pops out. And what it's doing when it pops out, when you're actually having an outbreak, I'll let you go. I'll leave it on this because that's actually kind of important too. Is that when you're having an outbreak, what is it doing? It's trying to spread. It's trying to get the hell out of it. So when you have an outbreak, there's usually because of some stressor, especially when it comes to herpes. Some sort of stressor in your life. Whether you have a cold can be a stressor. You know, for people that get cold sores, it's also herpes virus. You know, it could be because they got sunburn. That stressor, the virus all of a sudden doesn't feel safe anymore and feels like the host is under attack. It comes out and has we experienced an outbreak, but really it's just the virus trying to get out and get away from you and spread to somebody else. So yeah.
It's like, you're the problem.
Yeah, right. I'm out of here, please. Right? So latency, chronic, acute. You know, so again, as you're studying these, I'll finish them up on Thursday. Pay attention that it's mainly vocabulary, right? You know, it's pretty straightforward vocabulary. So hopefully this chapter isn't too tough on you. All right, if you have any questions, come up and see me. Otherwise, we'll call it a day, and we'll see you all on Thursday. Tuesday will be the exam. Yeah.
So wait, Thursday we didn't have class because I was at the hospital. I had to give you a doctor.
No.